Lecture 39, Experimental Psychopathology. Currently, psychiatric diagnoses are made on the basis of signs and symptoms, superficial manifestations of underlying pathology or disease. The various syndromes of psychopathology, schizophrenia, bipolar affective disorder, anxiety disorder, and the like, then represent clusters of symptoms and signs that tend to co-occur. In the medical model, a disease is a syndrome whose underlying pathology is known. That is, we know what's causing the signs and symptoms to occur. Scientific medicine treats pathology, not symptoms. In medicine, symptoms are not the disease. Progress in medical understanding is marked by a shift in focus from symptoms and signs to underlying disease processes, to underlying pathology revealed by laboratory analyses of structure and function, whose results are interpreted in light of a theoretical understanding of normal function. Consider the example of fever, manifested by chills, a symptom about which patients complain, and increased body temperature, a sign indicated by a thermometer that a physician can observe. Well into the 19th century, medical nosology included a large number of different types of fever, yellow fever, and so forth, based on the symptoms that accompanied the fever and the circumstances under which the fever occurred. But nobody diagnoses and treats fever anymore, because fever is viewed simply as a symptom of underlying bacterial infection. Physicians may try to reduce a patient's fever as an emergency measure, but most of their efforts are devoted to identifying the underlying infection through procedures like blood tests, and then treating it through medications like antibiotics. The same logic applies to mental illness. In medicine, pathology affects bodily functions through lesions of anatomical structures, like a skull fracture or lung cancer, abnormalities in physiological functions, like hypertension or sinus arrhythmia, a heart condition, or infection by microorganisms like the influenza virus, bacteria, fungi, or whatever. Modern medical diagnosis is based on evidence of these pathological conditions as revealed by objective laboratory tests. And there are parallels to this situation in mental illness and psychopathology. So, abnormalities in mental structures and processes are roughly analogous to the anatomical and physiological abnormalities encountered in physical medicine. In these cases of psychological deficit, something's gone wrong with the patient's basic mental apparatus, the cognitive, emotional, and motivational systems that govern the person's experience, thought, and action. Presumably, there's also some underlying biological abnormality that contributes to the abnormality in mental function. Then we have abnormalities in mental states, or mental contents, the thoughts, feelings, and desires that are constructed by mental structures and functions. In some cases of mental illness, the mental structures and functions themselves are essentially intact. In the case of abnormal mental states, abnormal beliefs, expectations, thoughts, feelings, desires, what have you, these are in some ways the mental analogies to infections. In medicine, underlying pathologies are revealed by laboratory analysis, interpreted in light of our understanding of normal structure and function. In psychopathology, such laboratory research is known as experimental psychopathology, and seeks to identify the causes of the patient's manifest symptoms. It is basic research in psychopathology as opposed to applied research in diagnosis and treatment. Experimental psychopathology comes in two major forms. First, laboratory studies of psychological deficit. These studies take experimental paradigms developed for research on normal cognitive, emotional, and motivational processes, and use them to understand differences between abnormal and normal mental functioning. Studies of psychological deficit in schizophrenia have a long history, dating back to the experimental work of Emil Kraepelin, a psychiatrist who worked in Wundt's laboratory using Donder's reaction time technique in studies of schizophrenia. Like Kraepelin, modern researchers who conduct laboratory studies of psychological deficit hope that their work will lead to the development of new laboratory techniques for psychiatric diagnosis, which will substitute for the symptom-based diagnostic procedures represented by the current Diagnostic and Statistical Manual for Mental Disorders. One highly prominent theory of schizophrenia holds that the psychological deficit underlying the patient's presenting symptoms affects the attentional system. According to this theory, schizophrenics suffer from a breakdown in selective attention that renders them highly distractible and unable to filter out irrelevant ideas. The patient shows thought and language disorder because he cannot keep track of what he's thinking and saying. He withdraws socially to shut out this chaos of stimulation. The information processing deficits in schizophrenia appear to begin at the very beginning of the information processing sequence. Think of the multi-store model discussed in the lectures on memory. In that model, stimulus information is briefly held in modality-specific sensory registers, from which it is extracted into short-term or working memory for further processing, and then encoded into long-term memory. Studies of information processing in schizophrenia have focused on the sensory registers, working memory, and attention. If things go wrong at these earliest stages of information processing, lots of other things will go wrong as well. A series of experiments by Dennis Secuzzo and his colleagues studied iconic memory in schizophrenia with a variant on the Sperling paradigm discussed in the lecture on short-term and working memory. Normally, iconic memory decays within about 1 second. In their studies, subjects are briefly presented with an array of digits or letters, followed within 1 second by a masking stimulus that effectively displaces the array from iconic memory, preventing it from being further processed into short-term or working memory. Therefore, identification of the elements in the array requires highly focused attention so that the subject can process the information from the array into primary memory before its representation disappears from iconic memory. In an experiment by Secuzzo and Schubert, subjects had to search for the letter T in an array of A's, or for the letter A in an array of T's. If the target was present, they simply said yes, and another trial began. The investigators then varied the stimulus onset asynchrony, or the interval between the onset of the array and the onset of the mask. Essentially, the amount of time that a representation of the array resides in iconic memory before it's displaced by the mask. All of this happens very quickly. From the time the subject focuses on the center of the display to the time the mask is presented, it's only about 1 second or less. And here are the results of the experiment. The schizophrenic patients were generally poorer at target detection than the controls, especially at the longer stimulus onset asynchronies. At the shorter asynchronies, nobody does very well. But at the longer asynchronies, the controls do better for the simple reason that they have more time to extract information from the array. But the schizophrenic patients didn't seem to profit from this longer stimulus onset asynchrony. Secuzzo and Schubert concluded that it takes longer for schizophrenics to transfer information from iconic memory to working memory. By virtue of this slower rate of information processing, schizophrenics miss a lot of what goes on around them and are more distractible. In recent years, much attention is focused on working memory in schizophrenia. You'll remember from an earlier lecture that working memory enables an individual to maintain information in an active state over short periods of time while it is being manipulated by other cognitive processes. This information may be extracted from perception or retrieved from memory. As such, working memory is critical for a wide variety of cognitive processes such as selective attention, including both focusing on needed information and inhibition of irrelevant information. A problem in working memory can permeate far into cognitive function, affecting memory, reasoning, problem-solving, and language. Working memory is often studied with variants of the Sternberg task, discussed at length in the lecture on methods in statistics. In the Sternberg task, a subject is asked to memorize a small set of items and then to search that set for a particular target. It's different from the Sperling task. In the Sperling task, subjects have to inspect a study set presented as a visual array. In the Sternberg task, they have to hold a representation of the study set in working memory while they search it. Sternberg's basic finding, you'll remember, was that response latency varied with the size of the search set, indicating a serial, self-terminating search process. An experiment by Paul Metzak and his colleagues compared schizophrenic patients with a group of normal control subjects who had been matched with the patients on such demographic variables as age and education. Like Sternberg, Metzak found that accuracy decreased and response latency increased with the size of the study set. But this variable had a greater effect on the performance of the schizophrenic patients than on the normal subjects. Performance especially deteriorated at the largest set size. It's as if the patients were overwhelmed by the information they had to process, maybe because they're processing information so slowly, as in the Sakuzzo experiments on iconic memory. Working memory consists of several different components. First, there are modality-specific buffers which maintain information in an active state. These elements are similar to the traditional concept of short-term memory, and there appears to be no problem with them in schizophrenia. Then there is a central executive, which actually guides various information processing tasks, manipulating and transforming information held by the buffers. Here is where the psychological deficit in schizophrenia appears to be located. Other research shows that there is a particular problem with a component of the central executive that represents and maintains contextual information that is relevant to current tasks, information about the task being performed, other information that's been recently processed, and what's coming next. This central executive appears to be mediated by the dorsolateral prefrontal cortex. Interestingly, this region of the brain is part of a system modulated by dopamine, and the antipsychotic drugs used in the treatment of schizophrenia are antagonists of this neurotransmitter. Studies of working memory illuminate schizophrenic deficiencies in central mechanisms of attention. But attention is also regulated by peripheral mechanisms, as when we turn our heads or move our eyes to shift our attention from one object to another. Philip Holtzman and his colleagues studied the peripheral mechanisms of visual attention with an eye-tracking paradigm, in which subjects are asked to hold their head in a fixed position and move their eyes to track a target that's moving smoothly across a computer screen. They then examined the subject's pursuit eye movements as they followed the target. Some aspects of these eye movements are not consciously perceptible to the subject, but they can be recorded by an electrooculogram, or EOG, similar to that used to record rapid eye movements in research on sleep or dreams, and also by other special devices. This measure of eye tracking provides a psychophysiological index of peripheral mechanisms of visual attention. Holtzman and his colleagues found that in contrast to the smooth pursuit eye movements that are characteristic of normals, schizophrenics show eye movements that are much more jagged. About 70% of schizophrenic patients show these anomalous pursuit eye movements. But interestingly, pursuit eye movement anomalies like this also showed up in the relatives of patients who were not themselves diagnosed with schizophrenia. Accordingly, Holtzman suggested that abnormal pursuit eye movements might be a biological marker for schizophrenia, perhaps indicating an underlying malfunction in the frontal lobe of the brain, and particularly those centers involved in the peripheral control of attention. Here is some sample raw data from one of Holtzman's studies so you can get a sense of what these pursuit eye movements actually look like. Very smooth in the case of normals, very jagged and irregular in the case of the typical schizophrenic. And here's aggregate data from one of Holtzman's studies. You can see that the schizophrenic patients show a much higher density of anomalous eye tracking errors compared to a control group of patients diagnosed with one or another form of affective disorder. And that was also true when you looked at the parents of patients diagnosed with schizophrenia compared to the parents of patients diagnosed with affective disorder, even though these parents themselves weren't carrying any psychiatric diagnosis at all. It's this parent data, especially, that suggested that eye tracking problems were a biological marker of schizophrenia. Laboratory procedures can be used to study emotional problems in schizophrenia and other mental illnesses, as well as cognitive problems like attentional deficit. Remember that in Bleuler's original formulation of the 4 A's of schizophrenia, schizophrenics don't just have problems in the cognitive domain. They also had problems in the emotional domain, what Bleuler called anhedonia, an affective disturbance in which patients simply don't seem to be emotionally responsive. Many schizophrenic patients show flat affect, no affect at all, or blunted affect. They show some emotional response, but not as much as normals. And still other schizophrenic patients will show inappropriate affect. They'll laugh at something that's sad, and they'll cry at something that's funny. In one study, Anne Kring and John Neal showed schizophrenic and control patients a series of films that depicted either an emotionally positive event, a negative event, or an emotionally neutral event. They measured the patient's emotional responses to these films. But when they did so, they were careful to measure all 3 components of an emotional response as defined by Peter Lang in the theory I discussed earlier: self-ratings of the subjective experience of emotion, facial expressions as an index of overt behavioral response, and skin conductance, a measure of the electrical properties of the skin as a measure of covert physiological response. When these researchers looked at the facial expression of emotion in response to the films, they found that, indeed, schizophrenics did not display as much emotion on their faces as the control subjects did. They showed fewer facial signs of emotion, and what they showed was less intense and lasted less long. But interestingly, when they looked at the physiological measure, skin conductance, the schizophrenic patients seemed to be even more responsive to the films than the control subjects were. There was much more reactivity in the skin conductance measure. So here we have a kind of disjunction in which the schizophrenics show less emotion in terms of their overt behavior, their facial expressions, but more emotion in terms of their covert physiology, skin conductance reactivity. Things got even more interesting when Kring and Neal did something that Bleuler hadn't done, which was simply to ask the patients how they felt when they were viewing each of the films. And when they did, they found that, by and large, the schizophrenics reported feeling as much emotion as the controls did. They felt positive emotion when viewing the positive film, and negative emotion when viewing the negative film, pretty much the way the controls did. So here you see a good example of how we can use laboratory techniques to go from clinical observation to looking at real underlying pathology. It's not the case, it turns out, that schizophrenics have no emotional responses to things. They're not exactly anhedonic. They feel as much emotion as anybody else, and those similarities go right to their physiology, what's going on at the level of the autonomic nervous system. The problem is that schizophrenics don't display much emotion on their face or in other aspects of their overt motor behavior, and this gives them the appearance of having flat or blunted affect. But when you take into account all 3 of the components of emotional response, it's not clear that they have flat affect at all. You wouldn't know this from clinical observation, but you do know it from conducting laboratory research that's guided by a clear theoretical conception of the nature of emotion. In addition to studies of psychological deficit, it's sometimes possible to create laboratory models of psychopathology, inducing in normal individuals a syndrome that, in at least some respects, resembles some form of actual mental illness. Laboratory models are rarely, if ever, exact replicas of mental illness, right down to the last detail. Rather, they're usually content to mimic just one or more characteristic symptoms of some syndrome. An early example of a laboratory model is the literature on so-called experimental neurosis, observed in animals that were being used in experiments on classical conditioning. In one experiment, a researcher working in Pavlov's laboratory presented dogs with a discriminative conditioning situation in which a circle was paired with an unconditioned stimulus, meat powder, but an ellipse was not, or vice versa. In either case, the animals eventually learned to make the discrimination, salivating to the circle, for example, but not to the ellipse. At that point, the investigators began to manipulate the conditioned stimuli, making the circle somewhat more elliptical and the ellipse somewhat more circular. There came a point where the animals simply couldn't make the discrimination anymore, didn't know which stimulus to respond to. And rather than just sitting there, the animals actually showed terrific signs of behavioral distress. They looked like they were fearful or anxious. That's the experimental neurosis, a symptom of neurosis, fear and anxiety, induced in a normal organism, a dog in this case, under laboratory conditions. There developed a fairly large literature on experimental neurosis, involving not just dogs, but sheep and pigs and all sorts of other animals. And it turns out that the animals were okay as long as they could reliably predict or control the situation. At some point, though, as in the circle versus ellipse experiment, the unconditioned stimulus was simply not predictable anymore. When the animal lost the ability to predict something that it had been able to predict in the past, it began to show signs of experimental neurosis. Later, in the 1950s, when Joseph Volpe began to introduce various forms of behavior therapy, like systematic desensitization for phobias, psychologists turned to fear conditioning as a laboratory model for the development of clinical phobias, the idea being that the phobic stimulus, snakes, spiders, darkness, height, open spaces, whatever, serves as a conditioned stimulus that comes to elicit a fear response. Later on, the model became somewhat more sophisticated as investigators began to think about the role of vicarious learning, social learning, rather than the direct experience of stimulus consequences, as lying at the root of phobias. And they also considered the role of preparedness in the development of phobias for snakes and spiders, dark spaces, open spaces, and the like. Similarly, obsessions can be thought of as fear responses in which the patient ruminates about the possibility that the stove has been left on, or the door has been left unlocked, or whatever. From this perspective, compulsions can be thought of as avoidance behaviors. Checking the stove, checking the door, it's a behavior that's designed to ward off the consequences of leaving the stove on or leaving the door unlocked. It has many of the features of an avoidance response. One of the interesting features of avoidance behavior is that it's very resistant to extinction. A dog in a shuttle box that's learned to move from one end of the shuttle box to another in order to avoid shock will do so indefinitely every time the conditioned stimulus is presented. Every time the tone comes on, the animal will just get up and move to the other side. And this is true even after the shock has been turned off. And if you think about it for a second, you see why this happens. If the animal is avoiding the shock reliably, it never gets the chance to learn that the shock has actually been turned off and it doesn't have to do anything at all. Similarly, if you keep checking the stove or you keep checking the lock, you never really find out what the consequences would be of not checking. So fear conditioning looks like a pretty good laboratory model of phobias and obsessions, and avoidance conditioning looks like a pretty good laboratory model of compulsions. In a sense, laboratory models constitute theories of how symptoms arise in actual patients because they're based on the assumption that the causative agents that effectively produce symptoms in the lab parallel those that are present in the real world outside the laboratory. Thus, laboratory models can be used to test proposals concerning the origins, treatment, and prevention of mental illness. And as such, any laboratory model can be evaluated on a number of dimensions. First, behavioral. Do the behaviors induced in the laboratory closely match the symptoms of the mental illness as seen in the clinic outside the lab? Conditioned fear pretty much matches what we see in phobias in the clinic. We also expect to see parallels in terms of causes. The kinds of causes we see in the laboratory case ought to find their parallel in the clinical case. One of the problems for the early conditioning model of phobia was that it just didn't seem to be the case that most phobics had the kinds of conditioning experiences that you'd expect to see based on the laboratory model. This problem was resolved to some extent when theorists began to think about the role of vicarious conditioning, social learning, as opposed to the direct experience of contingencies between the conditioned stimulus and the unconditioned stimulus. Another parallel is a cure. Joseph Volpe, the pioneering behavior therapist, introduced systematic desensitization as a cure for phobias, and a very effective treatment it was. Systematic desensitization looks an awful lot like extinction, so there's a very nice parallel. The conditioning model of phobias suggests that the occurrence of phobia could be prevented by preventing the learning experiences in the first place, either by preventing the subject from having the direct experience of negative consequences of an encounter with a phobic object, or from having the kind of social learning that we now think is really implicated in the syndrome. And finally, we would hope that the biological substrates would be the same, or similar, or analogous in the laboratory case as in the clinical case. So, for example, in a laboratory we can measure conditioned fear in terms of physiological responses like heart rate acceleration. And we can do the same thing with phobic patients. In fact, one of the features of behavioral treatment of phobias now is to measure the patient's fear response physiologically, not just in terms of self-report or overt behavior. One of the most interesting laboratory models of psychopathology is the learned helplessness model of depression. You'll remember from the lectures on learning that Martin Seligman and his colleagues discovered that prior exposure to inescapable shock interfered with escape and avoidance learning in dogs. In their analysis, prior experience with inescapable shock taught the animal that shock was uncontrollable, and this learning generalized to the new situation of the shuttle box. The learned helplessness experiments underscored the principle that in instrumental conditioning, the organism is learning to control its environment. The animals in these experiments learned to be helpless, but Seligman and his colleagues also observed that they looked and behaved as if they were depressed. And if you've ever seen a sad dog, you know exactly what they meant. This led Seligman to propose that learned helplessness is a laboratory model for some forms of depression, that some people become depressed by virtue of a history of uncontrollable, aversive events in their lives. Subsequent results by Seligman and others moved beyond this kind of anecdotal observation to identify a number of parallels between learned helplessness and depression. Depression, like learned helplessness, is characterized by symptoms of passivity, negative expectations, lack of aggression, loss of appetite, and sexual interest. Some depressives, like the animals in the learned helplessness experiments, seem to have histories of life experiences in which they would have learned that outcomes were independent of their behavior. Depression, like learned helplessness, can often be overcome by treatments that change the patient's beliefs and expectations. And just as depressed patients respond to antidepressant drugs, so helpless animals respond to drugs that stimulate the norepinephrine system. Individuals who are relatively invulnerable to depression often have a life history characterized by many mastery experiences. Similarly, Seligman and his associates found that animals can be inoculated against learned helplessness by giving them prior experience with control. And finally, Animals who have undergone learned helplessness treatments give evidence of depletion in the norepinephrine system. So in terms of the kinds of features by which laboratory models of psychopathology are evaluated, the helplessness model of depression looks pretty good. The learned helplessness model of depression, as originally formulated by Seligman, is a pretty good model, but it's got some problems. For example, Lynn Abramson and her colleagues noticed that people who are exposed to unpredictable and especially uncontrollable aversive events don't always become depressed. Sometimes they become angry. Abramson and her colleagues proposed that it's not the unpredictable aversive events themselves that's the problem. It's how the person responds to them, how the person interprets them, and in particular, how the person explains them, a problem known as causal attribution. Abramson proposed that people who are exposed to uncontrollable aversive events become depressed if they explain those events in a particular way. Social psychologists had already identified three major dimensions along which people make causal attributions. First, to internal versus external factors. Did this happen because of something about me, or was it just luck or the work of somebody else? Stable versus variable attributions. Is this cause always present, or is it just an occasional thing? And global versus specific attributions. Is this a cause that affects everything, or does it only affect some particular aspect of my life? Lynn Abramson, Lauren Alloy, and their colleagues found that persons who are at risk for depression tended to make global, stable, and internal attributions concerning important negative life events. That is, they explained these negative events in terms of something about themselves, a stable trait that affected outcomes in a wide variety of different domains. If bad things are always happening to you, if there's nothing you can do about them, and if it's something about you that prevents you from doing something about them, you'd get depressed too. And that's the idea. Such a pattern of causal attributions is depressogenic, in that it predisposes the person to react in a depressive manner to the occurrence of negative life events or to the absence of positive ones. In addition, Abramson and Alloy noted that normal people have an illusion of control. They think they're in control of events even when they aren't. In contrast, depressive people have a somewhat more realistic view of control. They're very quick to pick up on when they're not in control of things. Then they attribute this lack of control to something about themselves as opposed to something about the situation outside. Abramson and Alloy identified this pessimistic attributional style as a risk factor for depression. It's a depressogenic way of explaining things. Now, of course, depression can be caused by lots of other factors as well, including purely biological factors like a problem in certain neurotransmitters. So Abramson and Alloy took another step, which was to identify what they called hopelessness depression as a subtype of depression. The helplessness-hopelessness theory is not a theory of all forms of depression. It's only a theory of a particular form of depression, what they call hopelessness depression. Now, while that may sound circular, it's really not. All Abramson and Alloy are arguing is that all depressions are not equal. They're not identical in terms of cause. Some depressions may be biochemical in origin. Other depressions may be environmental in origin. Hopelessness depression is a depression that has its origins in unpredictable and especially uncontrollable aversive events. Another prominent laboratory model of psychopathology underlies what's known as the dopamine hypothesis of schizophrenia. According to this hypothesis, the symptoms of schizophrenia and their underlying psychopathology are caused by excessive activity of a neurotransmitter known as dopamine. Now, in fact, autopsy studies and also some brain imaging studies indicate that there are increased levels of dopamine metabolites in schizophrenic patients, and that's consistent with the dopamine hypothesis. Moreover, Phenothiazine drugs, which are used in the treatment of schizophrenia, block the neural receptors for dopamine, impairing the uptake of dopamine by postsynaptic neurons. So the fact that there are increased levels of dopamine metabolites found in schizophrenic patients, and that antipsychotic medications operate to reduce dopamine levels, these are both factors that are consistent with the dopamine hypothesis of schizophrenia. But another piece of evidence comes from a laboratory model of schizophrenia known as amphetamine psychosis. Solomon Snyder and his colleagues, working at the National Institute of Mental Health, found that the administration of certain drugs known as amphetamines can actually produce some of the symptoms of psychosis, particularly schizophrenia, in rats and other laboratory animals. They also noticed that the habitual heavy use of amphetamines by humans can produce some of the symptoms of schizophrenia as well, particularly hallucinations, thought disorder, and delusions. These amphetamine drugs have the effect of increasing dopamine activity in the brain. So this laboratory model, first studied in rats, then in monkeys, and then in humans who abuse amphetamine recreationally, provides further support for the dopamine hypothesis of schizophrenia. Research on psychopathy, or antisocial personality disorder, illustrates how the development of a convincing laboratory model of psychopathology can also stimulate studies of psychological deficit, and, for that matter, how studies of psychological deficit can influence the development of a laboratory model of psychopathology. The enduring tendency of psychopaths to engage in antisocial behavior and their persistent failure to respond to punishment has led to extensive research comparing psychopaths and controls on measures of response to aversive stimulation, avoidance learning, punishment, physiological arousal, and the like. All of these experiments are essentially studies of psychological deficits in learning. And what they've shown us is that psychopaths are indeed not particularly responsive to aversive stimulation. They show a failure of avoidance learning, and they fail to respond appropriately to punishments when they're delivered. Interestingly, they learn from rewards, but they don't learn from punishment. They learn to approach things, but they don't learn to avoid things. Joseph Newman and his colleagues noted the strong similarities between the behavior of psychopaths and that of rats with lesions in the septal area of the brain. The septum is a portion of the limbic system. It's a subcortical structure, and it's known to be involved in the reward system of the brain. Animals with lesions in the septal area do not freeze when they're punished. And although they don't show a generalized learning deficit, they're rather poor at passive avoidance. They're poor at learning not to do something in order to avoid punishment. They're also very poor at delay of gratification. In short, these animals show performance deficits when they're required to suppress or alter habitual responses in order to avoid aversive consequences. They're very impulsive. So experimental psychopathology, using paradigms derived from the learning laboratory, can be used to explore some of the psychological deficits that seem to appear in the case of psychopaths. And rats with lesions in the septal area of the brain can be used as a laboratory model to study both the origins and the possible treatment of individuals with antisocial personality disorder. Another example of the link between laboratory models of psychopathology and studies of psychological deficit is provided by the study of hypnosis. Hypnosis is a social interaction in which one person, the subject, responds to suggestions offered by another person, the hypnotist, for various kinds of imaginative experiences. Most of these hypnotic experiences involve alterations in the monitoring or controlling functions of consciousness. Hypnotized people see things that aren't there, they fail to see things that are there, they remember things that didn't happen, they can't remember things that they did when they were hypnotized, and so on. They can be unable to move their limbs, a kind of paralysis or catatonia. And what's interesting about many of the phenomena of hypnosis is that they show a kind of phenotypic similarity to the symptoms of hysteria, that is, the dissociative and conversion disorders. When you experimentally investigate the phenomena of hypnosis, you discover that hypnotized subjects can show contradictions or dissociations between explicit and implicit expressions of perception and memory. So, for example, subjects experiencing hypnotic analgesia nevertheless show unaltered physiological responses to painful stimuli. Subjects experiencing hypnotic blindness or deafness or post-hypnotic amnesia will nevertheless show priming effects from the stimuli that they can't see or hear or remember. And when you test patients with dissociative and conversion disorders, you discover that they also will often show unimpaired implicit memory and implicit perception. The dissociative and conversion disorders are very interesting, but they're also very rare. Hypnosis is much more common, so research directed at understanding hypnosis may also shed light on the mechanisms underlying the dissociative and conversion disorders. Experimental psychopathology is an interesting enterprise because it allows us to connect up the laboratory and the clinic, the scientific side of psychology and the applied side of psychology, to try to deal with problems of mental illness. Studies of psychological deficit allow us to move beyond merely the description of symptoms of psychopathology to understanding the pathological mental structures and processes that cause these symptoms to occur. Laboratory models allow us a new way of formulating and testing theories about the origins and treatment of various forms of mental illness. And finally, experimental psychopathology may allow us to develop new diagnostic tools for the assessment of mental illness. Just as physicians now employ laboratory tests to diagnose physical illness, so someday soon, psychiatrists, clinical psychologists, and other mental health professionals will be able to move beyond diagnosis based on symptoms to diagnosis based on underlying pathology.